Mr. Chairman, ladies and gentlemen, my name is Felix Behan. I'm a plastic and reconstructive surgeon of one of the older brigade, need I say it, as I look at. However, we have done something here today under the suggestion of Mark Ashton on how I do it in relation to keystone reconstructions from orthopedic referrals from my hospital at the Western General, full stop. The keystone concept is an architectural design, and I refer you to the individual images there, that the wedge of that thing is an arc stabilizer, whereas if it's a square, the brick would fall out. If it's wedged, it's locked in. And I use the word of an arc flap. Years past, but Alan Bridle suggested the clever word keystone, which has been quite satisfactory. Just a bit of architectural history here. The Colosseum in 69 to 70 AD could only go up second, third, and fourth floors because each of these arcs had a wedge brick, and you can't collapse because of the nature of it. There have been characteristics which have broken the rules in plastic surgery. Why should it get hyperemia? And why can I close under tension? The staging of these is just by observational findings. I have not got any scientific evidence except hypotheses of why this works. But when I've done over 3,000 over 25 years, and these things are repeated, the tensional closure and the red dot sign are characteristics of this particular area. I can't help thinking the triple response of 1924 of looking at the Lewis definition and explanations needs scientific investigation. The characteristics of the KPIF also seem to break rules. Pain does not usually occur. The tightness is there, but pain does not usually occur. Aesthetics go in the Gillies manner of liking like for like. Complications are rare from the vascular point of view, but the complications that I've experienced are when premature removal of tension sutures allows the wound to pop open. That's the main area of issue. Economically is a vital word, because some of these procedures can be done within an hour or two if they're complicated and long, whereas some of the microsurgical procedures take a longer time. And finally, we get somatic sensory recovery in about 6 weeks, 8 weeks, as is usual, and the swelling and edema tends to resolve. My suture technique is also simple. I use a locking mattress suture for the tension sutures on the convex and the concave side of the flap. Locking mattress sutures is just something I came on to in the latter part of my career, but you just put the loop of the needle through part of the area of the mattress, and they're very easily delivered and removed, whereas sometimes buried mattress sutures can be a testing part. Ordinary mattress closes the most of the wound, but for epidermal perfection, I use the continuous nylon to go from to get wound closure. Now, this particular article with Sancerre and myself by invitation, he wanted me to put all my references that I'd done at the time here on a paper, and there are actually 14 of them of the various publications I've done at the time of this publication in 2015. Again, it was Sancerre, who's popularized the notion of suprafascial and infrafascial circulation with angiographic conformation. These are the presentations I've done ad nauseam. You're sick of hearing me talk about it. I'm sick of hearing myself talk about it. So that's just part of history. But look at this. The keystone arc is there. And when you think of it and join the opposite extremes, you have a double VY island. And don't forget, it was Diefenbach in the 1850s at the back on the back streets of sometimes in Germany, when he could close defects on this on the first floor landing of his surgery, and the blokes used to spit the blood out the window, but he found that islanding could give you closure easily with few sutures. So when you think of the keystone, you might argue that it's got a history back in time from the Diefenbach stages. Now, you might have a diamond-shaped thing, depending on the anatomical confinements or the surgical defect. It could be a rhomboid, or I've also used my Amiga variant, leaving a third attached. And that third attachment rule in all the flaps is the keynote of my reconstruction. I do not skeletonize perforators. And I think that takes away the sympathetic, the autonomic, lymphatic network that must sit up every perforator before it goes into the final stage. But if you do not skeletonize them, and that's one of the drawbacks of the propeller flap, because they do it so they can get twisting. And also, if you have a skeletonized perforator, one can only say that kinking can occur. And with a 5% plus complication rate with propeller flaps, this way overcomes most of the problems. How does a plumber bend the copper pipe? To avoid kinking, he sleeves it with a plastic sleeve. A little basic technique of how it all began. And every registrar that leaves me puts his own version of what this is all about. But this is the basic. A defect, say 9x5 thing, design your flap on the muscle belly of the gastroc mass. You didn't put a keystone up along the anterior tibial line because that's tightness. And there ain't too many perforators along your shin line. And the second thing is you create the island, but the proximal end distance of this bridge flap is only at the dermal epidermal level. These are the two areas of closure. You've got the size of the original problem and you've created a second defect, and you can preserve longitudinal running structures, as in this case here, at the sural nerve. There is the area of flow, and all this area underneath here has multiple random perforators supplying it. And how do I know it? Well, the flaps go pink. I can't produce that angiographically, but I know the flaps are going pink. Now, there's another broken rule in plastic surgery. How do we close this under tension? We just close it under tension because it's tight. And if I think, gentlemen, if these flaps were going black 20 years ago, do you think I'd be opening my mouth? No. But there is a feature of the hyperemia. There's a cyanotic change of a small dot, which is the hyperemic point, bleeding more on the flap side than the exit side. There's the suture coming out. There's the suture going in. You can see the suture line there. Then you close it. You got mattress locking around the convex and concave side. The remaining wound is closed with ordinary mattress, and then a continuous island produces epidermal perfection and the vascular flare at 42 minutes, and there's the appearance of 7 days. And the wound dressing technique must be done by someone who knows. I cut my loops, I don't take them out, I just take the tensional points out there at 7 to 10 days. Some of the mattress at the non-tensional points are taken out additionally, and these mattress ones here, which are locking, stay in 3 weeks plus. The hypervascularity. I have only 2 references in relation to this hypervascularity. Brendan Coventry in Adelaide talked about the facilitator of vascular perfusion following a lumbar sympathectomy, and he has his explanations with nociceptor polypeptide facilitators. That's the wording he uses, things I cannot understand, but that's his wording in the article. But Cheng Lo, our plastic surgical colleague, also did a PRS publication, which is acceptable, the keystone concept and the effects of islanding in that particular publication. So those 2 guys I'm grateful to for putting scientific references into this work. My findings are only observational. Now, here's another lower limb reconstruction, a little bit different from the last, but this is the importance of aesthetic repair. There is my melanoma removal. There's the fascia. There's the 5x8. There's the bridging flap. And there's the fascia divided. People say you don't divide fascia. People say you leave a little bridge of island there. Totally unnecessary. But it just allows you to close in this manner. But more importantly, if that suture removal technique is maintained, that is the aesthetic outcome. And it's hard to get perfection in surgery, but this technique of using 1, 2, and 3 with mattress and otherwise produces that. And the poor lady, if they do have a skin graft defect, must wear trousers, but most of them are very pleased to wear shorts in summer. The case now of this sequence, the lower limb and the video of this chronic malleolar ulcer in which microsurgery has had its hand in the pie, and this is the defect we talk about on video to summarize it. Okay, now recording 3, 2, 1. In this 55-year-old male of 110 kilograms has had the problem of an ulcer in the medial malleolus for the last 14 months, measuring 3 by 1.
The persistent edema around the lower lip here is 29 centimetres measurement over the malleolar distance, right throughout circumferentially. In the past, he had an accident in June of 2010 following a forklift compression injury, the fracture of his calcaneum, his cuboid and metatarsals. And he had the ORI around about the 19th of July 2010. Microvascular wise for soft tissue cover, there was a posterior tibial artery was repaired with a vein graft, as well as a micro repair of the plantar nerve. And on the 23rd of July, coming around now with the camera, he had a radial forearm, free flap, to the lateral aspect of the dorsum, while raising this dorsalis pedis flap to cover something. I haven't got those full clinical details, but the resultant defect of the medial malleolus is the cause of his ongoing problem. His edema is persistent. He's been in hospital a week. He's now got flexibility in the dermis, which is an important thing. So I'm going to do a raise of fasciocutaneous island on the posterior medial side with perforators there to cover that defect, graft behind, and hopefully generate lymphatic permeation and therefore help to reduce the edema of the lower limb. Also,
my flap design is in the S1 dermatome. I leave that area only with the epidermal dermal cut. I undermine to allow transposition to occur there. And as you gently go up in the fibrous tissue, even with blunt dissection and preserving the lower part of the medial side of plantar saphenous nerve, you can get closure there. And you can see on the release of tourniquet, perfusion comes down to almost a scar area from the previous surgery. And it slowly goes distally because there's pink dots there in the suprafascial compartment of the lining of the flap. You can see how the closure there by the suture technique I've repeated. There's a defect behind, and there is the outcome at 3 months, fully healed. I beg your pardon, at 4 months. The edema has resolved. Now, why is it that when you do an island flap in this particular style, creating more scar tissue, but obviously facilitating some lymphatic drainage, and it'd be like the lymphatic sympathectomy effect on vascularity, improving color and perfusion. Could it do that likewise with lymphatic channels? The edema resolves in these cases. This thing was solved within a month, and having had almost 2 years of chronicity on the ankle. Another case, a popliteal fossa defect. There is an area 15/7 in a chronic smoker in a motor car accident. Yes, you can put a skin graft on there. And yes, you can do something local, and you can see something this way. And the tight closure is the thing. But look at the video.
4, 3, 2, 1. This is the problem on the medial side of the right lower limb, on the medial side of the knee joint. The defect 15/7. The history as we go across here in this 62-year-old male who had a motor truck accident on the 26th of July. Following that, he had 2 operations for debridement because of hematoma collections. The past history that he's got a history of alcoholism, hypertension, hypercholesterolemia, and he's an excellent smoker. Up we go. We do the pinch test. I can close that there without any worry. So there's the first keystone island I'm going to do at the top here, into the defect, closing there and advancing it down to that point. The inferior one, almost yin-yang, will be along the line of the tibial crest, based on perforators on the medial calf, turning onto itself, undermining that, and hopefully getting that defect. And the hardest part will be the medial side of the tibial tuberosity, which may need a grafting. However, if I can advance that fully, that should be overcome if I can bring that point across to here. Cut. 4, 3, 2, 1. This is the problem.
Now the tissue is plain. There's the fascial lining. There is perforators you can see coming there. But this is the important aspect. I use my index as a blunt dissector to minimize all damage to the random perforators in that muscle complex so that you can get closure without undermining nor dividing some of those vital links. And this double keystone idea is all sitting within the L4 dermatome. In that indicates the alignment as my architectural compass in which to confine the areas of the design. Now there's the closure in position before the tourniquet is released. And therefore at 90 minutes, you have a video here of what goes on. The closure is there, and the skin graft, the secondary defect, is in the inferior aspects. That is closed in 90 minutes.
Right. This is a fasciocutaneous on the medial quadrant of lower gastro, turned into itself, VY point there. This is a carved keystone style vascularity, almost in the manner of a keystone design, but based on perforators coming from the medial side there, Michael, which are named, which sort of perforators?
Septocutaneous.
Septocutaneous long attachment to the medial gastro. Full vascularity, no hassles. And it's pinker than the surrounding tissues. Graft for the secondary defect, cut.
Another shot of the same, sometimes later, before the graft is reviewed and assessed. The dates will tell you possibly 2 to 3 days later. But at 9 months, that's the important aspects. There's the closure achieved. There is the tensional point there on the line of the medial side below the popliteal fossa that had a granulating wound for about 2 to 3 weeks in a smoker. The graft down here is barely discernible, and the area here had a bit of slower healing as well. But we had the restrictions of smoking in not allowing us to get perfection, as is my style, and I would like in all these flaps. Now look at this guy. 32 years of a chronic ulcer in the lower limb and 14 operations. He had a fasciocutaneous island flap on the superficial peroneal nerve, and when the orthopedic surgeon said he cannot have this, it'll be his lot in life, I'll just show you what the plan is with the video.
There's a fascia, there's a keystone, there's the location, there's the turnaround, into the defect there, there's a white there, perfusion there, and pink there, should be okay.
Now we go from the operative sequence, the debridement, the chronicity, the scarring, the deformity, and the inconvenience. Fancy have to have a shower with a plastic bag on your leg over 32 years. Fancy the chronicity of that ongoing pain. Look at the edema of the lower limb. So normal surgical procedures or techniques are adopted. We just debride the wound down to the outer taper of the bone. There's the mark out of the flap. And with the superficial peroneal nerve axis there, approximately, I don't get an angiogram, it's always findable there. There is a keystone variant, this is almost rectangular. There is the raising of the flap just on distal to that axis there, nor have I skeletonized it, as I keep saying, and it's in the L5 dermatome. And the turnover, as you showed on the video, creates, that is just closed directly. You might say, why do it? Whereas if I didn't do an island, we'd lose half or distal third of the flap because that's been going on for X number of years. But islanding hypervascularizes the flap as long as a third is attached. That's my finding. And the red dot sign is the suture point, which confirms its viability. Now there is the person's and his healed wound, and the PACE's characteristics are noted. The pain is almost zero. There's no pain now. Aesthetically acceptable to that red mark out dart sign of the anterior tibial. The complications were zero in this case here. The economics of time, getting him healed after 2 operations, whereas he had 32 years of an alternative, and the somatic factor of return of recovery of sensation with the resolution of edema and swelling signify the importance of this technique style. Here's the patient's description of what he went through.
You're on video now. Tell me how the improvement of the second operation is regarding comfort.
It's a lot easier to walk.
Yes.
Even after the second operation, there's no limp or no noticeable limp, which has surprised me.
Which you had before.
Which I did have. And
edema and swelling.
Swelling's unnoticeable now.
fourthly, you said you can feel it when I wrote on the
I was
3.5
going to feel
years from the first operation, roll your foot outwards, and it's only 2 months since the medial operation, and that's where it sits. That's still numb.
But I can feel every touch down there.
Okay, and you're pleased with the overall functional recovery. And what about work?
I'm back at work.
Step, go.
Here's another case. Costello type 2B with a compound tibial fracture, 14/6. Exposed metal, exposed tendons, exposed everything. Yes, this can be closed by microsurgical features. But I can say one thing, in the medico-legal world, when such patients come to me for an opinion regarding compound injuries, the number that come through with non-union in the orthopedic or bony healing factors down here needing a bone graft are quite considerable, because some of these fascial microvascular flaps either don't let the fascia heal, or the fascia is not included in the flap, or something is there that doesn't allow bone healing. This case had that amount of metalwork installed with this compound fracture, and he had a superficial peroneal nerve, KPIF style, going around the total lateral compartment of the lower limb and L5 in this dermatome sign. The fascia is there. Now, in the initial cases I was doing, I divide the superficial peroneal nerve, and the resultant anesthetic area on the dorsal of the foot was, I thought, a small price to pay in relation to complete healing of the bone. In my subsequent experience, now I detach gently, leaving a perineural sheath around the nerve, and there's been no complication from the point of view of flap failure. Looking at the release of tourniquet, you can see the gentle perfusion of hyperemia, and depending on where the perforators are coming through or linked up, you can see the irregularity of that perfusional coming, where the pinkness there will spread distally and fully to the end of the wound. The secondary defect over the perineal compartment is mesh grafted, and the dates will show you what it looks like in theatre, perfectly healed. But sometimes we have a little problem with smokers, and this bloke had an issue there with a bit of slower healing at the point, but the video tells the story.
Press the other step. Are you running? Okay, on we go. Cool, okay. Right there. The back there is in the position. Going up the apex there. Secondary leg down the back here. Fresh green coming up. We've just dropped the artery legs. Ding, ding, ding. Okay. Background coming up. There's a secondary defect. We're going to graft. Okay.
Yes, the smoker's touch, a bit of slow healing, a bit of cyanosis, didn't imperil the healing at all. But the important thing is, edema was resolved. There's been no post-operative edema. How can it occur? Have we opened up lymphatic channels by this islanding technique? Now there's the appearance, no swelling there, back to normal. Now look at this case. This is another interesting one over the tibial tuberosity. You can see the previous scars of previous areas of work. There's the size of the defect, 9/6, going through his usual vac dressings. And there has been a modification of the keystone design. The video now will just show you what the plan is.
The methods of reconstruction of this male, the defect 9/6, everything and everything. However, with our experience in fasciocutaneous island flaps of the lower limb, based on perforators of the perigeniculate circulation, it'll be done in a manner keystone style with hypervascularities turning from that to that. The refinements are these. The midline patella scar is obvious. The transverse line across here is obvious. Michael has Doppler 3 perforates in that vicinity, which normally I go blindly and just turn the defect down the lateral area of the lateral compartment, across there, guzzling across the scar and turning it around. And that fasciocutaneous arm flap of the overall keystone variety will be elevated to 1/3 and turned on itself, and the skin graft to the secondary defect. Michael now will explain the essence of the science of Doppler localization of these. If it be necessary, in my hands today, I have not reverted to that particular technical investigation, but now Michael will explain his reasoning. Cut. The method.
Now, the basic technique again. There's the Ireland design cut, limited by the design factor of previous surgery. I don't know what for, but there's something to do with his knee. Skin and subcutaneous tissue only. Don't go in and divide longitudinal running neurovascular structures. The flap is raised, as you see here. There's the fascial lining. And the blunt dissection technique with the index is a very satisfactory way of doing minimal harm to the perforators, as I keep repeating. I use vascular clips to hemostasis. I don't use diathermy at all. And there on the release of tourniquet, you can see perfusion coming through. I'm about to apply a vascular clip. Now, the tourniquet release, this is what we call our Omega variant. We just put it in a U-shaped manner. It is islanded, but it is detached 2/3 and 1/3 proximally is intact. And look at the circulation on the release of tourniquet. You can see the irregular flow. Look at it going to that distal point there, because it must have a perforator sequence down there. Look at it going towards that medial side there. It must have a perforator sequence here. This must be dependent on the subdermal plexus. It's not flowing in the same quick manner, but it has not detracted from the overall success of the case. Now, there's a time frame, and they'll be smarter in time frames, but basically that is the area. And as a result of the superior nature of the perfusion with increased hyperemia, I can take out the dog ear. En passant, I just take out the skin and epidermis, should I imperil the flow distally, but having done many of them now, I just take out the skin and epidermis, fold in the remaining tissue, and in she goes with a mesh graft there. And there's the appearance of everything at 4 weeks. This is how the suture looks. There is the locking mattress suture at the main tensional points. There's a few interrupted mattress to flow on, and there's my continuous nylon, which I just clip at 7 to 10 days to get perfection, as I showed you earlier in the covering of the wound. Now, here is the patient's response initially in theatre at 6 or 7 days.
G'day. How do you feel? Excellent. How's the knee? Any pain with the knee?
None whatsoever.
Okay then. Just show your range of movement. Up she comes there. So that's approximately 45 degrees at the stage. That's the first movement we've done. And leg elevation off the top of the bed, which makes the orthopods also harmoniously comfortable. So you happy with all the procedure?
Very happy indeed.
Okay then. Now, Rob, you're on video. Tell me how you feel.
Excellent.
Okay. Since I started you doing straight leg raising, show me what you can do, which is more than you were doing when I arrived here on Thursday.
Dramatically.
Now, thirdly, bend your knee and so much you can bend, which at this stage looks approximately 45 degrees. Okay. Rotate it inwards. Rotate it outwards. And that's healed well. 3, 2, 1. Mr. Morris, you're on video now. Tell me about your knee. Explain the result.
Absolutely ecstatic.
Why do you say those words?
It's the way it's healed, the range of movement, the speed in which it's healed has just been excellent.
Show us the bending range of movement. Show us how far you can go. You're still not weight bearing, are you? Straighten her out again.
Still no weight bearing.
And it's still about 6 weeks plus since the operation. You feel well. Yep. And you're pleased with the overall results today.
Pleased to put in mildly.
Thank you then. Thank you again.
Now, all those factors of the previous patients of PACES, pain, aesthetics, complications, and economics, are all featured in his own verbal description of his opinion of the outcome. That was all unedited, untutored, and it was off the cuff. Anyway, case number 6, compound fracture, lower third tibia. This bloke had some weeks of slow healing because of the nature of the lesion, and you can see the gentamicin beads there offered in by the orthopedic department. And this is how the closure went. Fasciocutaneous island flap, superficial peroneal nerve. This is lower down near the ankle. Tends to be a bit more worrying as you get distally, and as a consequence, we'll turn that around. And here is the video now to show you the technique itself.
Is there. The scar is there. The superficial perineal nerve is there and going distally. That come across to there, and secondary defect will be split skin grafted over lateral levers. At the same time, they can take off the lower end or fibula.
Same story again, fascial lined, divided, clips, perfusion, circulation, preserving the sural nerve, more division, more development, more things, just self-explanatory. A video to show you the color of perfusion coming through.
The video indicates there's perfusion there. The color of the they've got a capillary return on pressure. I should have a capillary return on pressure, and I have a capillary return on pressure, Rebecca. And I turn that over, and the perfusion on the depths 1, 2, 3, 4, 5, 6, 7. I have full viable flap to cover that wound. Okay, the video.
A little sidekick for the junior staff members, how I skin graft, often from the same side to save you a double tourniquet prep. However, when you use the tourniquet, the skin graft applicator machine, make sure when you take the skin, you release the gear fully open, and it self-lays the skin back along the alignment where it came from, and therefore the plastic plate can be put on so evenly without going through other stories there. But that's only a minor variation. Post-operative appearance, fully healed, fully peeled, fully pink flap. Now, up to the patella. Compound fracture of the patella. I can't comment on the orthopedic reconstruction of the patella, but that television aerial concept there is amusing to me. Simplicity in surgery works, and why wouldn't 1 or 2 wires do on that? But why you got a network there looking like a bee's hive? Anyway, this was sent down from the country. There's the open wound. Asked us to close it. The vac dressing in preparation. The exposed area of the metal. We did not take the metal out to denature that, and it's all designed within the L3 dermatome. There's the video of what we did.
This 38-year-old male, 5 weeks ago with a motorbike accident, with an ORIF of the patella. In the fragments you'll see on the X-ray, which are unbelievable. He's got a compliance factor, and he's got a hole. The idea is to do down the L scar, down the outside point, down the collateral side of the knee, and turn that point eventually around to cover this here with a VY closure, hopefully on the area of the apex of the thing. The flap, the closure, the turn. Okay. 38-year-old male. Occurring there. Back on the deep surface here. You can see multiple areas of perfusional change on the deep surface here. Ding, ding. Blood, blood around the fascial lining, indicating, and there's blood and blood, blood, full cover. Now we'll have closure there and VY. Cut, circulation.
Now, one can make the point here that I use the WEC clips for microvascular type techniques to stop any necrosis from a hemorrhagic, from a diathermy point of view. There is, you can see that is not totally red, but it is certainly on the perfusional side of a little bit cyanotic, but that completely indicates there is perfusion there. And having created the ardent, the circulation's got nowhere else to go but up and down the perforators. Whereas if you leave a dermal bridge there, the line of least resistance means that would go out and possibly jeopardize flow. Hence the reason and the principle of the ardenting. Closure of the wound, you can see there of change there of a variation indicating the increased perforator line there without angiographic confirmation, less so in the middle at the crease side of the knee and more so along the bottom line there. And if kindly, this is the important part here, we can take out the dog ear. to save a secondary procedure. And this is what it looks like. There's the defect, which will be grafted. There's the closure with the variations in change. There's the dog ear, which always in other plastic units around the world come back in 6 months, we'll take it out for you. And this is what you do, providing there is good circulation and you do it.
The increase in dermal perfusion. The increase in dermal perfusion is creeping up in both sides there. It's fully perfused around here. Red dot signs throughout this area. And the final point is now with the tourniquet still on, I'm going to take out the dog ear. Because at the dermal epidermal level, the contribution of that to the flow is not as significant in my experience as that of the fascial base. Tourniquet down, thanks. There is the excision I'll cut. Yeah.
The post-op appearance, the closure of the wound, the normal appearance there, the fully perfused flap. There's no evidence of any skin necrosis there. The graft satisfactorily taken, and this is approximately at 25 days and a full range of functional recovery. This non-compliant patient refused to come back to any 4 post-operative reviews. Hence, I've got at the 3.5 weeks there approximately what it looks like, but I got no final photograph of it. Another difficult case in a chronic hemophiliac in which her weight was in the 120 kilogram mark of this lacerated knee joint region following a traumatic fall with that amount of weight on board. And if you want to skin graft that on a hemophiliac, that's your business. But if we can close it by a simple flap, it can be achievable to give you a rapid healing. There's the size of the defect. There's the size of the hole. There's the keystone on the upper lateral area where the soft tissue and suppleness will allow us to get perfusional closure. We go raise the flap, put it around there, tourniquet on board. Here's a technique people are concerned about, putting a ReadyVac in. I do a U-shaped ReadyVac on cavity 1 and cavity 2. And I just go blindly underneath the flap. I don't look for any signs of perforators that might injure, as these are well perfused with multiple perforators throughout. We go on to the next one. You see the closure. The convex side is done initially. Our concave side is done initially before we close the convex side, before the tourniquet is released. And you can see and elements of edema, elements of slow perfusion at that level, and there's the time frame there. But there is the appearance at 7 to 10 days, totally pain-free. For a chronic hemophiliac who's used to medical management in all levels, was thrilled that she had no pain in that closure. Aesthetically, I've got like for like. Complications were 0, but I made sure the sutures, I stayed in, I think, 6 weeks, if I remember correctly, because knowing that amount of edema and that amount of swelling, it would have been a slow healer. And I think I left my locking mattress sutures there up to a 6-week period. But you gauge the wound. You take out one of these locking mattress sutures and it starts to bleed. Well, there's your answer. Come back in a week. Let it settle. That's the outcome. And no worries at all there. She has the aesthetic issues of appearance. She has complications have been 0. It's been well managed, and she's very pleased also that it was pain-free throughout, who couldn't stand any more ReadyVac applications. Now, this is an interesting one. This guy of a compound tibia, much like I had earlier before with the tibial tuberosity, and he had a gastroc flap. Now, when a gastroc flap is put there to recover and repair a wound, it must be innervated. There's no point in putting muscle tissue up there if there's no innervation. If there's no innervation, it fibrously sort of deteriorates. And in this case, that gastroc flap, which I had to repair, was cutting, it felt like carpet, the way it was repairing itself. There are the gentamicin beads from the orthopedic department. Again, there's the flap, there's the graft, there's the ulcer, there's the genta, and he's got a tragic sort of potential. and I don't want to say amputations recur, but they offered me, they didn't want to go near microvascular. They said, what's something simple you can do to close it? And I said, I'll use my usual keystone application in the L5 dermatome, as you see here. Here's the external fixateur. There is the rotary beads. There is the gentamicin bulbs. They're all sitting around there together, hoping to get rid of any infection. But let me show you, because of the division between the bony ends of non-union in a fibrous mess and a fibrous mass. There's the mark out, lateral popliteal. There's the mark out in the L5 dermatome. I'm going to turn that flap to cover the area of the bone. A video will show you how I raise the flap.
Okay, there's colour there. There's colour there, yeah? That a mere? Yeah. We're down to there, we're down to there, we're down to there, and I'll see that should come across to there in a few moments. Colour, 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 colour. That'll colour up in a very short. It's up to there, it's up to there, it's up to there, it's up to there. We now have perfusion throughout the flap. Give me a pause. I'll see the last part. The flow is usually the dermis, and the fascial layer usually has circulation running as we have there. Cut.
Okay. The hyperemic phase is starting to develop. Usually takes 15 minutes to get that hyperemic flare phase compared with the normal tissue there. The size of the defect, 10 by 20. And then we start, and often if I see a perforator that restricts flow, I do clip it, but in the main, I try to preserve and get around them. There's the turnover, muscle circulation is intact. Now we start here with the closure. There's the suture point. It's bleeding more on the flap side than the receiving side. And there's the ultimate outcome with ready-back completion. 7 days or otherwise, but look at this slide here. There's the external fixateur. That edema of the lower limb was in direct apposition to that metal frame at the day of operation. Within 24, 48 hours, that's the patient's left index he could put underneath. Now, why has our flap created an edematous line to release the swelling of the tissue? And again, I hypothesized it could be a similar effect of, if the hypervascularity comes from a sympathectomy effect, could we get lymphatic dilatation in the same manner, because we preserve the perforators, which all go up through randomly in the base of the flap, which is 1/3 attached. Now we just go, there it is, 9 months, fully healed. But look at this, look at the Ilizarov issue. And we all know the story of Ilizarov, where he went away on holidays, and rather than compress the bones together with a pair of metal frames together, the Russian patient detached and loosened the area between the attached rib lines of the external fixateur, and a bone fragment developed between the two. Look at the success of that bone fragment in an infected area. Whether you saw the gentamicin beads, he fully healed. There's video for John. He'll tell you how he's feeling.
Ready, 3, 2, 1. John, you're on video. Tell me about your procedure. You are happy this time?
So far, I'm happy with this time. I haven't had a chance to get out of bed yet, but looking forward to it.
What about pain?
No pain.
What about your impression of how you feel compared with the previous one?
Actually feels a lot more finer. I find myself a little bit more maneuverability is far greater than it was previously.
Okay. Anyway, the thing is healing well. The graft is there, and the swelling's got out of your knee. Can you comment on the swelling coming out of your knee?
Well, just swelling went down unnoticed to me.
Your team picked it up and it's dropped by a centimetre in volume underneath that frame. Just put your finger on the button. There is the size. There is we couldn't get that unit of that 5 ml syringe under there at the time of operation. Good. Ready, 3.
Now, here's a bit of activity.
Now, so walk with me. Come towards me. Yeah. Tell me, give you one of the crutches. And when did that little story occur? When you just threw them away and walked up into it?
I actually walked into the kitchen by accident without my crutches, and then I didn't realise I didn't have my crutches with me now.
It's going on now for 9 months since the operation.
Yeah, that's correct.
Okay, Chris is going to take the external fixateur off soon and x-ray the bone shape. Well done. And now, so walk.
Now, in another case, from an international referral line, skiing in Aspen, compound tib, multiple things, and there is the size of the defect. There's the ORIF procedure. There's the chronicity of the video, and it shows everything.
Who has basically a closed fracture of the tibial plateau and proximal plateau, ended up with an open reduction in internal fixation 9 weeks ago in the USA while skiing. He developed a hematoma following the surgery at Truckee in the United States. Back to Mr. Acro, who drained the hematoma, wound breakdown. Now we've got a defect approximately 8x3 over tibial tuberosity. 66.
There's the wound, there's the closure.
10 by 4 centimeters. The back dressing has produced granulations in the distal half of the wound, and we've got to debride that area there to get into fresh granulation cover. Holding the leg inwards, fasciocutaneous arm flap. Basically, in the keystone design, it'll be an FCIF in that direction, turned on there, cover the defect, and anything back here might be split skin grafted if I can't close it. Fully aware of the lateral popliteal area, the limits of the flap, approximately, ruler again, 14 centimeters, I'd say. Ruler, thank you. Is 16 centimeters by 10 centimeters approximately. That's turning onto there, and that's the most important area of cover, and it'll be based on perigenicular circulation and some perforators from the lateral gastro-perforator complex.
The usual story, as I've done earlier. There's perforators that come through, which I had to divide in this case here. There's a red dot sign bleeding more on the flap side than the receiving side. And the dog here has been taken out en passant. There's the suture wound there. There's the closure of the first wound dressing. And there is the postoperative appearance. And here's the patient's response. Not
Now,
all patients are grateful.
Roll the knee inwards, please, George, to show the extent of the flap. I'll get you now to bend your knee fully, a straight leg raise, right up high as you can. Bend your knee fully, fully down, fully down, fully down, fully down, and out she goes straight again. Right, down she goes. And just tell me how you enjoyed the experience.
I didn't enjoy it at all, to tell you the honest truth.
That's good.
But it's still, the swollen bit here is sore, and it swells up when I do the exercise.
And you've seen the orthopods on Friday.
I am.
So, now,
Now, this poor bloke from Sudan had that chronic osteomyelitis for 20 years. And there is a simple situation of closure. There is a video of what it went on like.
yeah, 3, 2, 1. We are on record now in this problem of a chronic osteomyelitis of the anterior tibia middle third that has been going on for 20 years. It is a defect, 15 by 8, with chronic osteomyelitis in a Sudanese that's had with the orthopedic department a bone plaster substitute, which is a sterile plaster of Paris calcium substrate, which is this very point here. So I won't touch with my marking pen, but I'll just put an arrow on that. That's the area of cortical replacement. We're going to do a fasciocutaneous keystone design cover based on the superficial peroneal nerve, lateral aspect, middle half, turning that onto itself, a fasciocutaneous Ireland flap, which is islanded, and rotated and undermined almost to the level of the perforator. Turned on itself, cover the defect, and grafting the secondary defect there. Up, 4. Yeah, 3.
Debriding, wound, orthopedic department, and that's the area of total area of closure. This is the special of the cortical replacement substrate, and that's the cost of the calcium mixture, which is a external cortical defect replacement from the orthopedic department. superficial perineal nerve is preserved, as I said in my earlier one. I skinned it off. I used to, in the final stages, skinned off the flap. It's in the L5 dermatome, and advanced upwards with blunt dissection. There's the fascia, there's the fascial lining, and there's the turn on itself there, and there's the closure, and there's the dog ear removal. Again, it's heresy to take out a dog ear in those sort of risky flaps. But with these fasciocutaneous keystone styles, it can be removed. And I'll just show you the video of that.
Do it from the inside, flip the camera, and you'll see the size of elevation of the dog ear. It's quite high. I'm going to do this, and then strip it off at the subdermis. The subdermis, shove the fat on board, and put a suture line across. You'll see the flush improvement of the circulation. You'll sew that up. At the subdermal level, that goes in. Suprafascial circulation has not been breached. That goes back inside. We close the wound, and like look at that. I'll wipe it here, and we have a little flow.
The closure, the defect, and everything. There's the mesh graft. There's the thing at approximately 8 or 9 days, and the patient failed to attend to follow up as he's healed. He just said, "Thanks, doc." Now, the final case is this one. This one case was sent to me in the 90s by Dave Hunter-Smith, having had 3 failed microvascular repairs. Or an amputation was offered, and somebody suggested that send it out to me at the West and see what I could do. You can see the chronic osteomyelitic defect on there. There is it being stabilized only by the bony external line of the fibula. And the dead space there, we had to overcome. I think in surgical terms, why the 3 free flaps fail, they folded them down the dead space and hoping it would heal. Dead space is a no-no and killer, and I actually did in the acute phase an iliac bone crest to fill the hole, which is contrary to surgical principles. But what do? I got rid of dead space because that's a bigger lethal area of potential loss compared with osteomyelitic degeneration. There's a video of it.
This shows the clinical problem of the lower third of tibia. The chronic osteomyelitic cavity is extensive, 10 by 5 centimeters, and as deep, going down to the marrow lining. The marker is used to indicate the 3 microsurgical free flaps which had been attempted in the past, all of which failed. There's a lat dorsi, a gracilis, and radial forearm free flap used to close this defect. Ankle movements are intact. This shows the clinical.
There's the size of the hole orthopedically, and there's the fibular support.
This is the X-ray.
Debridement is straightforward.
As part of the procedure.
The mark out of the flap. Now, I used to never do the debridement right to the wound. I get my flap marked out and then cut the debriding tissue in case I got caught.
Okay.
There is a mark out there. There's a raising of the flap.
This is the important part of the raising of the flap.
There's a blunt dissection of the digit, as you've seen me repeat repetitively over the last few times. There's a superficial perineal nerve coming over here. There's a turnover, and there's a muscle mass, and there is about to sitting on that last little strand, and that will go across now and transfer itself across the defect. There it is, superficial perineal nerve, fascial lining, and therefore now we completed this stage of marginating that area so the flap can fit in across the wound. And there is the completion of the debridement, so it'll sneak in across there. The closure of the wound, the deep fascial flow, the sutures there in the mattress technique, and excess tissue then is removed. And there is the closure, and it is sitting in nice perfusional alignment to achieve healing. I got good vascular flare at this stage.
We now commence the final stages of closure of the wound.
The secondary defect is grafted.
before we now commence them.
And there is the appearance post-op at about 14 days, a well-healed flap, the defect covered, an iliac bone graft in that showed no sign of infection. We had a Redivac drain and just, you know, let it stay a longer period. There's a successful graft there. Now there is the appearance of the patient in mobilization, and this should be a video.
The first operative phase, after a period of immobilization at the 2-week level, the patient was finally assessed from the point of view of recovery. There was no complications evident at this stage. The graft had successfully taken. The patient was pain-free and could dispense with his crutches.
And he was back jogging at 3 months. So gentlemen, it's salvage,
They showed pain-free
no
movement.
amputation, and he's happy with the outcome.
The first
Got it in the press in the West in the 90s. To what end? I don't even care. But I say this, in reconstructive surgery, you must have both barrels loaded. Microsurgery is irreplaceable in certain areas, and local regional repair can also be applied. I always use that expression, always have both barrels loaded. No one's better than the other. I'm happy with my technique until you get au fait with the restriction of it. It has a little bit of a learning curve, but it's like your first bungee jump. Do one, then you just flow down the limit. But let me show you 2 international references that have come through. Bill Cuson from Michigan came out here as a visiting college professor years ago and wrote this article in PRS in the mid-1915s or 16s. And he said, it's the best flap in the world, untutored again, sir. And more importantly, Jeffrey Halleck has just been in contact with me from New York that the Nelligan book on perforators is going to be redone. And he says there's one glaring admission, there's no chapter on the keystone. Gentlemen, thank you for everything. I've 25 years now has been summarized. I only keep on talking this way because of its simplicity and its worldwide applications. And what do you do in the back of Burma or back streets of Pakistan without a microscope? You must be able to do these sort of local regional procedures. Thank you again.